Good evening, ladies and gentlemen, and dear colleagues. This is Zuberi, Secretary of Bangladesh Medical Physics Society and Medical Physicist at Levitt Cancer Hospital and Super Specialty Center, Dhaka, Bangladesh. I wish all of my colleagues around the world a happy International Medical Physics Week. I'm pleased to welcome our speaker, moderator, and all of our participants in our fourth webinar session of BMPS on the option of International Medical Physics Week. We will be very glad to see that our today's program will be conducted by our president of BMPS, Dr. M.D. Akhtaruজ্জামান, who is working as Chief Medical Physicist and Radiation Control Officer at Evercare Hospital, Chattogram, Bangladesh. And he is also a member of Education and Training Committee, Asia Oceania Federation of Organization for Medical Physics, AFOMP. And he is also adjunct postdoctoral research fellow in University of Western Australia, Perth, Australia. Now I welcome to moderate this session to Dr. Akhtaruজ্জামান. Now it's on your floor.
Thank you, Mr. Zuberi, for organizing such a nice series of webinars as part of the regular activities of Bangladesh Medical Physics Society. So first of all, on behalf of the Bangladesh Medical Physics Society as a president, so I would like to welcome our speaker and all the participants to be part of these events. So today we have a speaker from UK, Mr. Sakil Zuberi. Currently, he is working as a senior radiotherapy medical physicist at the Royal Marsden Hospital in London. Before working over here, he has been working in several places, including University of Warwick, NHS Trust, and so on. So before starting his working at different places, he has completed his undergraduate from the University of Dhaka in 2002. Later on, he has done his MSc in electronics and physics at the University of London in 2007. And after that, he also has completed his master in clinical science, specialization in medical physics, radiation oncology medical physics in 2018. He is a member of IPM and British Institute of Radiology. He is a certified and licensed practitioner from the Health Professional Council. Now I would like to welcome Mr. Sakil Zuberi for his presentation. Mr. Sakil Zuberi, please.
Hello, hi, I'm Sakil, and I'm very happy to come in front of you and meet all of my colleagues in Bangladesh. I'll quickly share my screen. Can you all see my screen?
Yes.
Right. So my today's talk will be about how we can establish a SRS program or SBRT program in the department. Assuming that the department doesn't have one, and then what are the steps that a physicist need to think of? And I will show some examples from my current hospital, which is Royal Marsden Hospital, where we have a very long history of SRS and SBRT program. We started treating here in 1990s. using Linux based, and then we started using exact track from 2006. We acquired a gamma knife. We acquired a CyberKnife machine for SRS program, and recently we have a second CyberKnife with a MLC capability. We have 2 sites, one in Chelsea and one in Sutton. The Chelsea site is TrueBeam, where it's a variant center where we use TrueBeams for the SBRT and SRS program using exact track as well. And in Sutton, where I work, we use Versa HD, so Electra Center. We have one ML Linac for the special SBRT cases, specifically trial oriented. So very quickly, I don't want to go to the definition of SRS or SBRT. Just to remind ourselves that we are talking here about image guided hyperfractionated EBRT. Just a quick background to it. So when the SRS program first started in the world, it started with gamma knife, where Lexell started back in 1960s, where he Hello, can you hear me?
Yes.
All right. So back at that time, the team used a frame so that they can stereotactically define a target, and then used the cobalt sources to ablate the target volume. But nowadays it's frameless. Mostly we go for image guidance for localization, and this is why imaging and image guidance is such a big important part in the current day SRS and SBRT. So we are trying to achieve a precise delivery with highly conformal dose distribution. And these doses, we will consider it as radical. Right. So when we talk about SBRT, we also need to talk about oligomets. So oligomet, so oligo term comes from meaning from a few. So oligo means few, and that means that the state of the disease is such that it's not widely metastatic yet, but only few, like 1 to 5 metastasis can be seen via imaging, and we can treat and we can control the disease and ensure a longer life from the patient if we combine this with the systemic treatment. So that means chemo, immunotherapy, and other treatments for other metastases which are already growing. Whereas the metastases which we can already see using imaging, we will be trying to treat these and try to locally control using SBRT. So each department will, or the guidance that we can find will have some specification about the maximum cross-section of the diameter that we can treat safely, and this will depend on the site to site. We also need to look at the patient's general health and how well the patient can tolerate these high doses as well. We also need to look at the patient anatomy, where the target is and where the dose limiting critical structures are. So this information will come to use a little bit later. Very quickly, before we go into detail, I would like to highlight all the things that we can treat using SRS. So SRS is when we try to irradiate an ablative dose inside our skull. And the main benefit or main usefulness of trying to irradiate such high dose stereotactically defined target is brain mostly will not have some motion compared to the skull. So we can, with high confidence, we can irradiate a particular volume with greater confidence. So that's how the SRS or stereotactic program started, and then gradually it went into the other sites extracranially. So within the cranium, we can treat the malignant lesions where we can see the lesions mostly coming from lung primary cancer, or breast, or rectal or bowel cancer. And with MRI, we will be able to identify these mets in the healthy brain tissue. We regularly treat single mets, multiple mets. Now there is a question: what's the limit of multiple met that we can treat? In our center, we almost once a month we treat 30 mets or 20 mets using CyberKnife. And still clinician, we will see later actually, that still clinicians believe that is better than whole brain therapy. We also treat post-operative tumor bed lesions. So where the patient already have removed, the neurosurgeon has removed the tumor, but to get the proper control and to be assured that there is no other disease left, we irradiate the tumor bed in different fractionations as well, and we'll see it later as well during the talk. We also treat some benign conditions like pituitary adenoma and then acurystic neuroma. These are not metastatic or malignant. However, they can create a big loss of quality of life for the patient. So we treat these as well. And in terms of SBRT, mostly, almost like 80% or 90% of the cases will be either lung, liver, or spine. There are some lymph nodes and bone mets that we regularly treat as well. And these are all the metastasis. Whereas some primary tumors we also treat using SBRT, namely lung cancer, which has a very good record of achieving control when we are treating the lesion using high proportionated beams. So these are the local practice. I just quickly want to show you what are the doses that we use generally. However, this whole field of SBRT is developing so fast, so quickly. Almost each year, we bring some new techniques or new fractionations or new constraints or something new in the field. So it's a very exciting field to work on at the moment. On the list here, you can see the brain which is SRS, of course, is shown to get only single fraction to 24. So clinicians will always want to treat a MET or multiple MET using the highest dose in one fraction that is achievable or possible. So main dose limiting constraint will come as the normal brain. So the normal brain 12 gray or 10 gray, not getting more than 10 cc of normal brain getting 12 gray is one of the main limiting structures that actually dictates what kind of dose we will be able to give. So the clinicians will go down up to 18 gray, depending on the clinical case, depending on what kind of meds. Is it a lung? Is it a breast? And then there are some other techniques that is coming increasingly popular. What is we now are calling SRT instead of SRS is a fractionated stereotactic radiotherapy, where the SRS dose is given in fractionated regime, and the reason is it will increase the therapeutic ratio in the patients where the large volume of the meds is irradiating a bigger volume of normal brain, or when we say normal brain, is the brain minus the GTV. So by fractionating the dose, we are trying to save or trying to compromise our target goal, but at the same time trying to spare the brain, normal brain, as much as possible. And it's also being used now when the meds are in critical regions like brainstem or chiasm, and of course in re-irradiation as well. So some of the technical bits that we need to consider before we think about running a SBRT program in the department. First thing is, we need to make sure that we are running this, or we are bringing this SBRT program so that we will regularly run it. It's not like we just treat one patient and then we don't treat for 1 month or 6 months, and then again treat one patient. We need to make sure that the whole system is up and running so that we can start and then we can regularly treat. And this way, the expertise will grow within the department, the teams will be working, and that means that it will be a far lesser risk of some kind of occurrence happening. Some of the things we need to consider that the modern LINAC, is it capable of running such precision treatment? And one of the things we need to make sure that the FFF energy is commissioned with utmost accuracy, specifically for the small fields. In my previous center, when we started doing lung SBRT, we found that our results were not close to our confidence level that we wanted to achieve. And then we end up recommissioning the FFM energy with the stereotactic detectors, with the new guidance that we have for small field dosimetry now, from both from AAPM and then so these are the things that you need to think before you can think about running an SBRT program, whether your machine is capable of doing it, is your treatment planning system can simulate such beams, whether the beam model is accurate enough, whether the imaging system is good enough, if your mechanical accuracy of the machine and the coincidence of radiation isocenter with the KV imaging isocenter is up to the limit where we want to be. These are all the things we need to discuss and find through our QA program. Then we also need to think about what kind of immobilization system we have, what kind of couch we have, and the couch, is it good for bringing the right tolerances. And then, of course, the TPAs need to be able to handle the multimodality imaging, registration. It should be able to deal with the MR imaging, and need to have the proper algorithms commissioned properly, so that we will achieve the right kind of accuracy. Multidisciplinary team, this is what I was talking about, that before we decide whether the patient is suitable, before we decide that whether we will gain something for the patient after delivering this SBRT treatment, it's very important to have a multidisciplinary team meetings running in the department every week, where we will be talking about each of the cases. There will be plenty of cases where the patient is not suitable because there is a metal plate, or there is a other comorbidity, or a patient is not fit for such longer treatments. So this is where it's very important to have a MDT in the department, which preferably commissioned by a medical physicist, this whole system of MDT meeting, and then later run by the radiographers or radiographer lead, where the radiologist who is specialized in MRI imaging, detecting metastasis, who will be attending and who will be giving a specialized opinion about what to treat and what's the extent of the treatment volume. And this is where all the teams, all the expertise will sit and find out what's the best way forward. Is it SBRT best way forward, or a radical treatment? As soon as we see or decide that we're going to treat, as soon as we have the planning MRI or planning CT in many cases, then we have very little time to finish planning all the approval, all the checks and everything, because we don't want to have a big time interval between the MR imaging, where we will be outlining the target, and then the delivery, because in many cases the mets grow very fast, and then, as you can see here, as from the literature, in 14 days it actually grew by how many percent here. So it's very important that the planning CT and the planning MRI has the absolutely optimized image quality, and also has the geometric accuracy that you need for such precise treatment. So we need to find out what kind of slice thickness we need. The MRI need to have the resolution such that when we fuse these two images together, we will be able to fuse it with our precision that we need to achieve. The IGRT part is also very important here because this is the image set that we'll be using when we will be localizing during the treatment delivery. So the geometric information that we will get from such CT or other modality need to be accurate, need to be recorded properly. We need to find out from the protocol that we will set up that what kind of patient setup the treatment position will be, what kind of immobilization will there be, because we want to take all the images in the treatment position for this treatment. Imaging artifacts, high atomic number metals are often seen in patients. These are the things that we will already discuss in MDT, whether we need to have some special algorithm or we need to optimize something for this patient. Or is it even not possible, because there can be a lot of the cases where the critical structure or the target volume cannot be defined from the images. And then in these cases, SBRT shouldn't be even be a case. These are just a couple of things that I put that we need to make sure that our slice thickness and the resolution is what we need. Patient immobilization, it's another thing that is very interesting. So in many of the SBRT treatment units that we use, we have continuous imaging guidance. And that means that in those cases, the patient immobilization is less important because we will be checking the patient position during the treatment, and any kind of misalignment will be corrected. However, patient comfort is a big thing that we need to consider here. The longer treatments, or at least longer than a conventional treatment, will mean that patient need to stay in the treatment position for longer. And the more uncomfortable the patient is, the patient will move more, and that means that we will need more correction, we will need more images. This is especially true for CyberKnife, where the treatment times can go up to an hour. And in those cases, we consider the patient comfort in patient immobilization so that patient can lie still. For SRS, whether it's a Linac or CyberKnife, we use a thermoplastic cast, which is universally now accepted that this is the best way forward. And then SBRT, sometimes we use some other abdominal compression tools to minimize the respiratory motion. Very quickly to the machine, different kind of machine that is available for us. The CyberKnife, which is where is my expertise are actually. This is one of the machines that we use in our center in Sutton. It has a a linac mounted on a robotic arm. That means that the linac can actually move around the patient and irradiate the tumor from a different direction. And this concept actually mimics the gamma knife concept, where the target will be irradiated from different angles. The couch is a robotic couch, so that means you can correct for any rotation in any direction, and also during the treatment, the imaging system will continuously, or depending on the radiographer's decision, will continuously every, say, 15 seconds or 40 seconds, or if the radiographer thinks that the patient is stable enough, it can be a minute long. And this imaging system will continuously track the skull or any other, maybe a fiducial marker or the spine itself, and will try to adjust the robotic couch so that the patient remains in the treatment position. And then we have the linac SRS systems. So we have the Novalis systems from Brain Lab, where we use exact track for imaging guidance. We have variants TrueBeam, fantastic. We are using it for a lot of SBRT treatments. And Electa is the equivalent, sorry, Varsa HD is the TrueBeam equivalent of Electa. And we, in our center, we use Varsa HD for our lung and some liver, and then the bone mate and some lymph nodes as well. So for linac ones, we mostly will be using the OBI system or the XVI system for CBCT. And then for the Brain Lab, we can achieve a more precise treatment accuracy using exact track stereotopic imaging system. Right. So talking about specialized TPS systems, for CyberKnife, we have Precision, which is specifically made for stereotactic treatments. And then we have Brain Lab's Elements for the planning for Novalis machines. And nowadays, Ray Station, Eclipse, all of them are capable of optimizing for non-coplanar and for stereotactic type prescriptions. As we already talked about, the imaging is the most important for these SBRT and SRS programs. And different imaging systems, we physicists need to understand the limitations and the usefulness of each of them, and the capability of each of them. So very quickly, the 2D matching. We can either use the room mounted, which is the exact track, or the gantry mounted, which is the VMAT, sorry, which is the CBCT equivalent. And then, of course, we have the CyberKnife also has the room-mounted image guidance, where the verification images will, as I already talked about, that will constantly correct the patient position. CyberKnife uses the skull tracking for the bony anatomy of the skull, whereas for spine, it can track the spine vertebra itself. And for liver and for prostate, we use the fiducial markers to track the target as surrogates. And this is for the exact track image guidance. I think I'm running out of time, so I'll just skip these slides and come to some important bits. So SBRT treatment planning now. Planning-wise, the protocol need to be established before any SBRT program runs. Everybody needs to understand what target volumes the clinician need to control. What are the definitions and what are the margins we need to use? So we generally, for SBRT program, we use the general ICRU definitions for all the target volumes and OAR. However, in most of the cases, GTV and CTV are identical, except some special cases, specifically for spines. The GTV can be identified using MRI or other modalities like PET, but the CTV for the microscopic extensions need to define from the ISRC guidance. So this is a classic case where GTV and CTV are not equal. Another case can be for liver mets or for brain tumor bed. So tumor bed, the CTV will be the surgical border that you can see, but we often use the PTV with some margin to ensure that we encompass it, all the disease. Then the PTV margin will be very much dependent on the site to site and from center to center. Physicists need to assess, and commissioning need to find out the margin that is required from the different setup uncertainties, the machine tolerance, and information from the motion of the CTV itself. Normal tissue dose tolerance is a very interesting topic in SBRT because this field is still evolving. So that means that you will go to different centers and you will see they're using very different dose tolerances. And we will see that different trials are trying to establish those constraints that better for the patients. So what we are seeing is each year these tolerance tables, the dose tolerance recommendations are changing almost every year. So it's very important that we keep on following the latest guidelines and latest findings. In our center, the things that we follow is the UK SABRE Consortium guidelines, which is an absolutely amazing document to read. So is the APM TG 101. And then there are also other consortium international guidelines that is out there, and trial protocols that already published their results in phase 2, some of them even in phase 3, some of them. But these actually will give you a good indication of the requirement for such a high risk treatment. And these need to be established in the protocol, in the local clinical protocol, and the local clinical protocol need to be reviewed regularly so that we can include the up-to-date information about this evolving field. So plan reporting, what are the things that we need to report after we finish a plan? So of course, prescription dose. We need to report the isodose that the target volume is covering to a particular percentage of the dose. So, sorry, so isodose covering the PTV to a particular percentage. So 95% of the PTV is covered by the prescription dose or prescription isodose. Then number of treatment and the frequency we need to report. We need to report the treatment delivery time, the target coverage. If there is a compromise, then of course we need to document the target coverage as well, and those two OARs. We also need to document the plan conformity index, the dose fall off, and the heterogeneity index. All these things are also ideally be reported. So SRS prescriptions, they differ from the conventional radiotherapy prescriptions, as you probably already know, but this is just to ensure that the rapid dose fall off is achieved. And the practice is, and this comes from the gamma knife time when Lesker first started doing it. So we prescribe a dose to a peripheral isodose value that encompasses just the target volume. So this means that for a cyber knife, which is almost a copy of gamma knife, classic gamma knife treatments, we try to prescribe the 50% isodose of the maximum value to encompass it, the GTV or the target itself. And we are allowed to go from 50 to 70 because in many cases, because the target volume is so small that you cannot achieve a high dose in the middle, or the shape is such that a peaky distribution is not achievable. So in some cases, we will see that we regularly deviate from 50% to 70%. But there is a limit how peaky the distribution can be. And the reason is if you put, so 50% isodose means that at the center of your target volume, you're allowed to give a double the dose. So if you're giving 24 gray to the target volume, you're allowed to go double the amount, so 48 gray at the center. But we're not we try to limit ourselves within 47% of that, so that the center of the target volume doesn't get overdosed, so that there will be necrosis, there will be edema, and all sorts of complications later. So we try to contain ourselves from 47 to 70%, and that's the best way to prescribe an SRS. The elements and ray station and the other TPS do similarly, just they do it in absolute dose values. So what our local practice is, just to highlight or give you the example, that for SBRT plans, I already talked about the SRS plans, which is at the bottom. For the SBRT plans, it's slightly different. So 95% of the PTV will get the 100% of the prescription dose. Now, this prescription will be around 70 to 77% of the maximum. And the reason is for SBRT plans in LINAC is not achievable. So 50% is not achievable. And partly because no matter how non-coplanar we go, we'll never get to a point where such high peaky dose distribution can be achieved. Right. So very quickly to the compromise cases that we often find ourselves in. So in case we find that our dose limiting OAR is overlapping or close to our PTV, we consider kind of 3 or actually 2 methods. So one is to see whether we can reduce the prescription dose. So in many cases, in the table that I showed, there is a range of prescription that we are allowed. So if it is not 30, we will try 27 or even 24. If the clinician agrees with that depending on the clinical case, this is something to go forward, we will do that. If not, if the control is more important, then we'll go for a compromised PTV coverage, where we will still respect the OAR, but the PTV coverage will now not be 95%, but we are still allowed to go down to 80%. So we will try to achieve as much as PTV gets the prescription isodose, and only compromise where we need to for that particular OAR. And as long as the total 95% of the PTV is still getting 80% of the prescription, is okay. And then the other method is to consider OAR minus GTV sparing, because where there is GTV, there can't be any OAR. And that's true specifically for brain, normal liver, brain stem. In those cases, we often deduct the GTV to report the rest of the OARs sparing. Now, coming into LINAC-based SBRT planning. So a classical dynamic conformal arc therapy, or DCA, that we used to use when elements were as I-plan, and we were in the very early stages of SBRT. We would rotate the gantry with a single gantry speed and with a single isodose, single dose rate. And we will just move the MLCs such a way that it continuously conform to the shape of the target. That was when we were using the dynamic conformal arc therapy type treatment. And now the treatment planning systems are more capable of doing stuff, changing the dose rate, the gantry speed, and that can have some benefits when it comes to sparing or bringing the dose even farther from the OARs. So that nowadays we often use the VMAT planning for SBRT plans. However, we try to achieve something like a DCA type delivery. So we try to impose constraints such that in the VMAT planning, where the conformal-like field shape can be achieved. So the gantry will move, but the MLCs will keep on conforming just to the target. And we often constrain the MLC motion speed during our optimization, and we also work on the objectives. We have a class solution that specifically does that job, so that the MLC field shapes will not hide the target and make the fields very simple. And I'll come to that later, why we want that. Collimator angle rotation, this is something that can take some time if the planning system itself is not optimizing itself for the best outcome. So this is where a considerable improvement can be achieved by selecting manually the best collimator angle. This is specifically true for multiple METs. In some collimator rotations, you will achieve far more efficiency than the other angles. This is where another thing that is different from SBRT planning compared to the VMAT planning. So this is where during the optimization, you may want to reduce the margin of the beam penumbra to the target edge. So this is where on the left-hand side, you can see for VMAT plans where we need a homogeneous dose distribution in the middle, we want some margin for the MLCs at the edge of the target so that we can achieve that homogeneous dose distribution. Whereas for SBRT, we don't need that homogeneous dose distribution. And for that reasons, we can put our all effort into the dose fall off and make a faster dose fall off. Right, so I'll quickly show you a couple of clinical examples to emphasize why we would like to use a DCA type delivery when we are considering a Linac-based SBRT. So this is a bone SBRT, 30 grain 3. PTV has CTV plus 5 millimeter. So as you can see, what we showed earlier, that I reduced the treat margin for the target. So the MLCs are just conforming to the target in two. This is two just randomly picked two control points. And a good thing about this is, as you can see, it doesn't have any small segments. It's open, and that means that it will not have any interplay effect. It will have no effect of the patient movement or during the delivery if the machine cannot achieve something. The dose distribution still will be what we already planned for. This is another clinical example. This is where I am showing what happens when an OAR is very close to our target. This plan is done on CyberKnife, and as you can see, we are treating the whole vertebra. The red inside is the CTV, and the blue is the PTV, and the purple is the cauda equina in this case, where we just achieved the required constraint. So what's happening here in this slide, as you can see, the thick orange line is the prescription isodose, and as you can see, the yellow isodose is the 23 gray. So this is where the Cauda equina where need to be outside this 23.24 actually 24 gray isodose, and for that reason, from 30 gray isodose orange to the yellow to 24, 6 gray drop in 2 millimeters, and because of CyberKnife treatment, we can achieve this. It's not achievable in such extent in LINAC, unfortunately. And this is where we made this compromise. However, the CTV is still getting a good coverage, and clinician is happy with the compromise to the PTV. Last clinical example, this is another tricky case where the lesion itself is in the brainstem. This is again a CyberKnife treatment where we try to achieve a high dose fall-off. In this next slide, I can show you that in 2 millimeters, it achieved from 24 gray to 15 gray, I think. So it's a huge dose fall off in this region. So in this case, as you can see, we didn't achieve the brainstem constraints that we agreed. However, we achieved the brainstem minus GTV. So in this case, clinician was happy because the disease was such that there was no such brainstem activity inside this volume. And he was accepting the consequences that we need to control the disease here. And as long as we sparing the rest of the brainstem, he was happy with that. Right, I had some slides on the QA, but looks like I'm running out of time. I don't know whether I should stop here or Mr. Khan, what do you think? Right. Okay. So I will just quickly go through a couple of the QA tolerances and tests that we follow. So these are from IPM report 81. And key thing is the Winston-Lust test, which is for the LINAC, which will tie the radiation isocenter with the KV isocenter with the mechanical isocenter. So this is a test that often the centers spend most time with when considering SBRT program. Equally important is the MLC positioning, which, as you can see, need to be less than 1 millimeter, which with the modern machines, often it is achieved quite easily. What are the things? Yeah, these are again detailed test, monthly ones. The previous one was daily ones that we need to do daily. And these are where our couch displacements and the reproducibility that we can achieve is less than 1 millimeter and 0.5 degrees. So one of the things that is very important for an SBRT program from QA point of view is to run end-to-end tests. So this is where we will be using films probably to see whether we can irradiate a specified volume with greater accuracy. And end-to-end tests are an excellent way of finding any unavoidable error, and then we can modify our mission maintenance or program accordingly. I'm not too sure whether I'm running out of time or whether anyone is there?
You can continue 5 minutes.
5 minutes. Okay, thank you so much. Thank you. So another thing that is equally important is patient-specific QA. I only have a couple of slides for. So patient-specific QA is required in current UK practice. So we try to do as much as possible SRS and SBRT QA. It's only when during the checking stage, planned checking stage, the experienced MPE or medical physicist decides that we don't need to do a QA on this. We only don't do it only then. And we have multiple tools for that. So mostly we use Delta-4 and Octavius for Linux-based SBRT plans. For CyberKnife, where it's not easy to use Delta-4 or Octavius, we use EBT Film QA with excellent results showing that our QA program and our SBRT program is running well with sufficient experience. Of course, as I said, if we can have a independent plan evaluation and dose calculation software, which we have. So every time we plan anything on Precision or in Ray Station or in Eclipse or in Elements, we run through RadCalc to see whether our dose calculation is correct. We went through a automated independent plan evaluation program as well. And we maintain a high level of accuracy and tolerance, tight tolerance in our machine QA. Only because of these, we sometimes drop specifically the SRS QAs, which is every week we have to do. If we do all of them, we will have to do 10, 20 SRS QA, which is not practical. So at the end, to summarize, the physicist should understand the limitations of each element of the technology we use during this whole process. So that is most important thing for a physicist, to know that what my machine can do and cannot do, what I can see and cannot ensure, what I can maintain, but I cannot guarantee, what can I measure, and what is the associated uncertainty. So these are the things that physicists need to understand regarding the machine and regarding the process itself. And another very important, I will like to remind again, is a treatment protocol and an updated, a reviewed treatment protocol that is brought by the experienced radiation oncologist and experienced physicist, and which is efficient, which is safe for the patient, is something that every department should have one and should have maintained. Thank you very much for your time. I hope it was useful, at least to some of you. So I will stop share.
Okay, thank you very much for your nice presentation. We have a couple of questions. So now I'm going through one by one.
Okay, thank you.
The first question is, how many fixed collimators does CyberKnife have?
So our CyberKnife has 3 types of collimators. So the CyberKnife in Chelsea is an old CyberKnife, which has only fixed collimators and iris collimators. So that has only those 2 collimators, and fixed collimators can come with 5mm, 7.5mm diameter, 10, 12.5, 15, 20, 25, and 30. Whereas our CyberKnife, which is one of the newest in the market, also has MLCs. So it has all the fixed collimators that I already mentioned, and iris, which can vary the same diameters that I mentioned, and also have the MLCs. MLCs are very useful for prostates, liver, which has like big lesions, and we can bring conformal beamlets, which can really reduce the treatment time. Hope that answers the question.
Okay. So the next question is for Gamma Knife, CyberKnife, Standard, IMRT, and BMAT, if all normalized to body maximum, approximately 50, 70, 90, and 90%, is correct for reasonable isodose lines to prescribe? Why is different isotones for Gamma Knife and CyberKnife?
So, right. So the thing is, for CyberKnife and for Gamma Knife, we are treating the target from all directions. So we literally have like 360, almost 360. So that means the beams that we are using, they are smaller in size compared to the diameter of the target. And because we are irradiating from all over, all the directions, our beams will create a dose distribution that is far more peaky than you can achieve in a LINAC. So this is one of the reasons why Gamma Knife straight away achieve a 50% isodose prescription compared to a roughly 80% for LINACs.
Okay. So now what's the difference, a special difference between IMRT, BMAT planning and SBRT? So except the dose, so what is the special difference between BMAT and SBRT?
So in VMAT on IMRT plans, as you already probably seen, that when you finish planning, you will have lots of small segments. The MLCs will vary in their positions from one control point to another with a significant amount. Whereas in SBRT planning, we try not to do that. We try to keep the MLCs as the fields as open as possible without minimum movement in MLCs. And the reason is because you have high dose rate going through each control point, any error in the movement of MLC, or even any movement in the patient, will bring into a very different dose distribution that you already planned for. So this is why we try to keep the MLC leaves, as I showed in the presentation, that our MLC leaves are such that they are almost like conformal arcs. And by doing that, we ensure that our machine is not running to its limit of its capabilities. It's only thing that we need for such SBRT plan is high dose fall-off in every direction. So during our optimization, what we do, we try not to use too many objectives. I actually forgot to include this objective list that we have in our class solution. It literally has 2 dose fall-off, one for the farther distance, one for the shorter distance. And then we only have one for CTV minimum dose objective, and then one for a DVH of 95% achieving the prescription isodose for the PTV. So these minimum contributions in the objective curve really helps the optimizer to achieve simple segments, and the dose fall-off is the only thing that we look for in SBRT plans. This is all true if not any OAR is close by, or we are not reaching any OAR dose constraint. If we do so, we bring that dose constraint into the objective and try to push very slightly, so that again, we only want to minimally move away from a DCA type plan.
Okay. So there are more questions. So first one is, would you please share some tricks for getting sharp dose fall-offs in Linux-based SBRT plan? So I think you already explained it, but it is a very lengthy discussion, I believe. So the another question is, would you please mention the maximum acceptable high value of the heterogeneity index when up to 145% of the prescribed dose is accepted as the maximum dose to PTB in case of Linux-based SRS SRT?
So, so as I said, this is something that locally need to be agreed with clinician. So having a very heterogeneous dose distribution, so peaky high dose in the middle, will affect the patient's experience or quality of life, and this will depend on side-by-side basis. So we try not to go beyond 77% or lower than 77% of the maximum dose for SBRT cases. And it's again because of the necrosis, because of the unknown effects that the high dose will give. So I cannot give you the exact value of the HI that we are limited, but you can easily calculate from it that we don't go below 77% of the maximum dose for our prescription isodose.
I think it is clarified. So probably the last question is, the dose verification result how show gamma passing rate 3% 3 mm or 3% 2 mm or 3% 1 mm? Is the analysis choose local or max dose in your department?
So for film QA, it's still, we are still kind of playing with it. One of the reasons it's very hard to agree such gamma passing rate or the criteria is the film itself is very noisy. So all the peaks and all the troughs that we have, instead of a smooth dose distribution without filtering, the gamma passing rate overestimates for film. So for that reason, we use very strict 1.5 and 1.5% for film. However, we are working on our film QA program. We are trying to use some kind of filtering so that we can bring something more meaningful for our film QA. For our Delta 4 and Octavius, we use 1.5 millimeter with 3% max dose, so not local.
Okay, so all of the questions are covered. So from my side, there is a very common question is, we are living in a least developed or the developing countries, you could say. So, and most of the SRS or SBRT cases are the Linux based. And I believe that, we do not have the, the cones or something, such kind of structural cones. We mostly do the MLC based, Linux based, but with the MLC, SRT or the SBRT. So what is your recommendation in that case? I mean, what should we follow and what is the criteria we should maintain in our department?
So there is a lot of published works already out there working with Linux-based SBRTs, SBRT treatments. So it's definitely possible. We need to have a strict QA protocol for the department. And one of the things that we often find in UK, that each department will have their own engineers, which makes our life so much easier, because we go to the engineers and say that, oh, this couch is bordering 1 millimeter on this tolerance, and can you fix it or can you improve it? And so such a important part engineers play to our work. They will try to find a way to bring any mechanical or any beam tuning, and that's one thing that I think we need to improve in elsewhere as well, where the beams are maintained, the machines are maintained in such condition that you can have the confidence to run such program as SBRT and SRS. One of the things that is useful is to understand the limitations. So like the one that I showed, the saver, spine saver, we try to irradiate spine using our Linux, just to check what kind of dose fall-off we can achieve. And unfortunately, in some cases, it's not achievable. So in some treatments, you definitely need a specialized machine like CyberKnife or Exact Track. Whereas in many SBRT sites, if we can maintain the machine, if we have the proper understanding of the limitations and the QA program, then SBRT is possible.
Okay, so the final question from my side again. So as you have the TrueBeam as well as the Versa HD, so do you do the SRS and SBRT with your existing Linux, or you use the circular cone with your Linux?
So we don't use the cones for the Linux anymore. Was that your question?
The question is, you have the Linux. Okay.
Yes.
So and the Linux TrueBeam and the Versa HD both have the 0.5 centimeter MLC, which is not tiny.
Yes.
Yeah.
Yes.
So in that case, do you use cone or use the 0.5 centimeter MLC for SRT and SBRT cases?
So on our Linux, we treat lung, we treat lymph node and prostate and some liver SBRTs. Only thing that we need CyberKnife for is the motion management, because of the continuous imaging that we get. This is something the LINAC is missing if you don't have an exact track where you can continuously image the target volume or any surrogate like fiducial markers. And without continuous targeting, without continuous image guidance, it's not possible in many other sites. Another thing is non-coplanar beams can achieve a very good dose fall-off in every direction. So mastering the planning technique using effective and efficient non-coplanar regime is very useful, I think.
Okay, thank you. Thank you very much for your interesting and nice presentation. Now I would like to hand over to Mr. Zuberi to conclude the session. Zuberi, are you there?
Yes, yes. Thank you very much for your moderations. And also thank you, Mr. Sakil Zuberi, for your insightful presentation on modern treatment techniques, SBRT and SRS. And we are very grateful to you for your time and your efforts. And also thank you our audience for making this successful program. And now I will invite our next webinar, which will be held in tomorrow. The topic is the recording and reporting to BRT treatments plans in the context of ICRU guidelines. The speaker is Dr. Mahfuzur Rahman. He is a medical physicist coordinator, lab at Cancer Hospital and Super Specialist Center, Bangladesh. We look forward to your participation in our next webinar session, and it will be the last webinar session on the option of International Medical Physics Week. And again, thanks to all of the participants and speaker and our moderator. See you next day. Thank you.